Hi, and welcome to our series on valve stenosis, where we break things down to help you master echo, starting with one of the most common, aortic stenosis. When it comes to evaluating how severe aortic stenosis is, echocardiography is the gold standard. It gives us everything we need, all in real-time, non-invasive imaging. In fact, according to the EAE-ACE recommendations for clinical practice, which is linked in the description, cardiac catheterization is no longer recommended unless echo results are unclear or don't match the clinical picture. Let me say that again. Echo is your go-to. Cath is only used in rare specific cases. Let's talk about what actually causes aortic stenosis. A bicuspid aortic valve, meaning instead of 3 leaflets, the valve has only 2. This abnormal structure leads to earlier wear and tear. Next is calcific stenosis of a normal trileaflet valve. This is typically age-related, influenced by lifestyle and gradual calcium buildup, leading to stiffening and narrowing of the valve over time. And finally, there's rheumatic valve disease. While it's less common in developed countries, globally it remains more prevalent than calcific stenosis. To recap, bicuspid valve is the most common cause, followed by calcific degeneration related to age and lifestyle, and then rheumatic valve disease. Now that we've covered the causes, let's move on to quantifying aortic stenosis, because knowing how severe it is makes all the difference in management. Aortic stenosis severity is best described using specific numerical measurements, and the ASE recommends focusing on 3 key parameters, as jet velocity, mean pressure gradient, aortic valve area. These are the core indicators we rely on during echocardiographic assessment. To make this easier to visualize, we've included a table of these key parameters on screen. Let's break them down. If the aortic jet velocity is, say, 3.9 meters per second, that places the patient in the moderate AS category. If the mean pressure gradient is greater than 40, that's a sign of severe AS. And if the aortic valve area is still greater than 3, that's considered physiologic, meaning the valve is functioning normally. However, if the valve area falls below 3 but stays above 1.5, we're looking at mild aortic stenosis. Now let's take a closer look at aortic stenosis jet peak velocity, also referred to as AVV max, or maximum velocity across the aortic valve. When a valve becomes stenotic and the opening narrows, blood has to move faster to keep flowing forward. This increase in speed creates more turbulence, which shows up as a higher velocity right at the stenotic area. To measure this, we use continuous wave Doppler with the Doppler gate placed at the aortic valve, most commonly from the apical 5-chamber view. This is where we get our peak velocity reading. Look below the baseline on your Doppler waveform. That's where the aortic jet appears, and then start tracing. If your patient is in normal sinus rhythm, you should average 3 beats. But if they have an arrhythmia, such as atrial fibrillation, try to average more than 5 beats for accuracy. Now, let's apply this to a real case. If we look at my patient's echo results, the AVV max is 3.97 meters per second. Now pause here. Take a look at the grading table on screen for aortic jet velocity. Where does a velocity of 3.97 fall? According to the guidelines, a velocity between 3 and 4 meters per second is classified as moderate aortic stenosis. So in this case, our patient would be graded as having moderate aortic stenosis based on peak velocity. Let's continue with how to interpret the next parameter, mean pressure gradient. The mean pressure gradient gives us another important clue about the severity of aortic stenosis. This value is derived from the simplified Bernoulli equation, which states that the pressure gradient across a valve equals 4 times the velocity squared. So, as the blood flow velocity increases due to a narrowed valve, the pressure difference across that valve also rises. Thankfully, we don't usually need to do this math manually. The machine calculates it for us. What you'll look for is the AV mean PG, that stands for aortic valve mean pressure gradient. Now let's look at an example. In my patient's echo results, the AV mean PG is 34.86 millimeters of mercury. Take a moment to check the severity table for mean pressure gradient. Based on the guidelines, a mean pressure gradient between 20 and 40 millimeters of mercury falls into the moderate aortic stenosis category. So in this case, the patient would again be classified as having moderate aortic stenosis, now confirmed by both peak velocity and mean pressure gradient. Coming up next, we'll look at the third key parameter, aortic valve area. The aortic valve area, or AVA, is calculated using the continuity equation, which is based on the law of conservation of mass and energy, meaning that what flows in must flow out. In simpler terms, the volume of blood passing through the left ventricular outflow tract, or LVOT, should still equal the volume passing through the narrowed aortic valve. So how does that apply to our echo measurements? The equation assumes that the stroke volume, or the amount of blood ejected through the aortic valve, is equal to the stroke volume measured at the LVOT. In this context, stroke volume is CSA multiplied by the VTI. So putting all of that together, the amount of blood, that is the VTI, that will go through the cross-sectional area of the aortic valve, must equal the amount of blood going through the cross-sectional area of the LVOT. Let's break that down even further, because we assume that both the LVOT and the aortic valve orifices are more or less round. The CSA is calculated using the formula pi times radius squared. This comes directly from the formula for the area of a circle. So the most simplified formula for cross-sectional area is CSA equals 0.785 times d squared. To simplify things for clinical use, this formula is adjusted and written as CSA equals 0.785 multiplied by the LVOT diameter squared. Feel free to pause here and take a moment to go over the math. Ultimately, these are the two formulas you need to remember. Now that we understand the concept behind the continuity equation and how we calculate cross-sectional area, let's walk through the step-by-step process for measuring the values we need to calculate the aortic valve area. Step 1 is to get the relevant values. There are three main measurements you'll need. 1. LVOT diameter. 2. LVOT velocity time integral. 3. Aortic valve velocity time integral. Let's go through each one. First, the LVOT diameter. You'll measure this in the parasternal long axis view, PLAX. Zoom in on the aortic valve and take your measurement inner edge to inner edge, or eye to eye, during mid-systole when the valve is fully open. Second, the LVOT VTI. This is obtained from the apical 5-chamber view using pulsed wave Doppler. Place the sample volume just on the left ventricular side of the valve. Use a low wall filter and trace the Doppler waveform carefully to get your measurement. Third, the aortic valve VTI. Also from the apical 5-chamber view, using continuous wave Doppler, align the sample gate through the aortic valve and trace the entire waveform to get the AVVTI. Once you've collected these three values, LVOT diameter, LVOT VTI, and aortic valve VTI, you're ready to plug them into the continuity equation and calculate the aortic valve area. Once you've acquired the necessary measurements, step 2 is to calculate the LVOT cross-sectional area, or CSA. Remember, we're using the simplified formula. CSA equals 0.785 multiplied by the LVOT diameter squared. Once you have that, you're ready for the final step. Step 3 is to compute the aortic valve area, or AVA. Use the continuity equation LVOT CSA multiplied by LVOT VTI, then divided by the aortic valve VTI. We have a sample case on the right side of the screen. We took the LVOT diameter measurement from the parasternal long axis view, the LVOT pulsed wave Doppler from the apical 5-chamber view, and the aortic valve continuous wave Doppler also from the apical 5-chamber view. Feel free to pause here, review the measurements, and try plugging them into the formulas. The next slide will show you the completed calculation. Did you get the same answer? Feel free to drop your calculation or any questions in the comment section. Now that we've calculated the aortic valve area, let's evaluate its severity. In our example, we concluded that the AVA is 0.75 square centimeters. According to the guidelines, an aortic valve area less than 1 is classified as severe aortic stenosis. So in this case, with an AVA of 0.75, the patient would be diagnosed with severe aortic stenosis. To wrap things up, when assessing aortic stenosis, always remember the three key measurements: aortic jet velocity, mean pressure gradient, and aortic valve area. We walked through how to obtain each value, how they relate to hemodynamics, and how to apply them using the continuity equation.
Welcome back to our stenosis series. In part 1, we talked about aortic stenosis, what causes aortic stenosis, and quantitation based on ASE guidelines. If you missed it, you'll find the link on our aortic stenosis video in the description. Now in part 2, we're shifting gears to focus on mitral stenosis. We'll break down how it affects blood flow, what to look for on echo, and how to apply the ASE guidelines in real clinical cases. Let's get into it. Let's talk about what causes mitral stenosis, because understanding the why behind the narrowing helps us better interpret what we see on echo. The most common cause of mitral stenosis worldwide is rheumatic fever. This is a post-inflammatory condition that leads to classic features like commissural fusion, meaning that the edges of the valve leaflets where they open are stuck together. Then we have degenerative or calcific mitral stenosis, more common in older adults. Instead of affecting the leaflets, this form typically involves calcification of the mitral annulus, making the valve stiff and less mobile. Other less frequent causes include congenital MS, which often involves abnormalities in the subvalvular apparatus, and secondary forms like carcinoid heart disease, drug-induced valve thickening, and systemic inflammatory diseases like lupus or rheumatoid arthritis. Each of these has a slightly different mechanism, but they all lead to the same, a mitral valve that doesn't open the way it should. Let's walk through the heart and uncover what happens in mitral stenosis. In a healthy heart, blood returns from the lungs, full of oxygen, into the left atrium. From there, it flows freely through the mitral valve into the left ventricle, which then pumps it out to the aorta and into the body. But in mitral stenosis, the mitral valve is narrowed. This restricted opening makes it harder for blood to move from the left atrium to the left ventricle during diastole. So the left atrium has no choice but to push harder, and over time it starts to stretch and enlarge or dilate due to the pressure overload. As the left atrium enlarges, it starts to crowd nearby structures in the chest. It can compress the esophagus, causing what's called dysphagia, or difficulty swallowing. It can press on the left recurrent laryngeal nerve that loops around near the heart, causing hoarseness of voice, also known as dysphonia. It may even push against the bronchi, leading to a chronic cough. This enlargement disrupts the heart's electrical signals, causing the atrium to quiver. This is atrial fibrillation, a chaotic rhythm that causes the atrium to stop contracting effectively. Because it's no longer contracting effectively, blood pools. This is a condition called blood stasis. Blood typically pools in the left atrium. From here, the clot or thrombus can travel. If it dislodges, it becomes an embolus. It can shoot into the brain and cause an embolic stroke. This is when it becomes a life-threatening complication. As the blood struggles to pass through the narrowed mitral valve, pressure backs up into the pulmonary veins, then back to the lungs. The lungs begin to fill with fluid, a condition called pulmonary edema. This brings dyspnea or shortness of breath, especially during activity. The patient also gets orthopnea. This is when the patient lies flat, fluid spreads more evenly through the lungs, worsening the shortness of breath. And when fluid pools overnight and wakes a person up gasping for air, that's called paroxysmal nocturnal dyspnea, or PND. As the pressure in the lungs continues to rise, we reach pulmonary hypertension, a condition where the arteries in the lungs become narrowed and stiff. This adds strain to the right side of the heart, which now has to work harder to push blood from the atrium to the tricuspid valve, through the pulmonic artery, and into the lungs. Over time, the right heart begins to fail, leading to right-sided heart failure. And when we get right-side heart failure, the blood backs up to the superior vena cava back to the jugular veins, causing jugular vein distension. The blood also backs up to the inferior vena cava, causing hepatic congestion, ascites, and further down causing ankle or lower limb edema. Meanwhile, less blood is making it through to the left ventricle, and ultimately, less oxygen-rich blood is reaching the body. This leads to fatigue, cold extremities, and exercise intolerance. When the demand for oxygen rises like during a workout or even walking upstairs, the heart can't keep up. That's when SAD kicks in, syncope or fainting due to lack of blood to the brain, angina or chest pain from inadequate oxygen to the heart muscle, dyspnea, which again is breathlessness, from both lung congestion and low cardiac output. Mitral stenosis begins with a narrowed valve, but its ripple effects are widespread. Pressure builds behind the valve, causing the left atrium to dilate. That enlargement causes compression symptoms, electrical disturbance, blood clots, and the risk of stroke. Pulmonary congestion follows as the blood from the left atrium backs up to the pulmonic veins and back to the lungs, leading to pulmonary edema, shortness of breath, orthopnea, PND, and pulmonary hypertension, causing the right side of the heart to work harder and over time leading to right-side heart failure. And through it all, because of the lack of blood going to the left ventricle to the systemic circulation, the body suffers from low cardiac output, low oxygen delivery, triggering the classic SAD triad. The clinical presentation of mitral stenosis often begins subtly, then gradually progresses. One of the earliest and most common symptoms is progressive dyspnea, that is, increasing shortness of breath, especially with exertion. This occurs due to elevated pressures in the pulmonary circulation as blood backs up into the lungs from the obstructed mitral valve. On physical examination, a patient may exhibit a malar flush, a reddish-purple discoloration over the cheeks. This is thought to be due to vasodilation and chronic hypoperfusion, a hallmark of long-standing mitral stenosis with low cardiac output. Auscultation of the heart reveals hallmark findings. At the apex of the heart, which is located at the left fifth intercostal space, along the mid-clavicular line, a mid-diastolic murmur can be heard. It is preceded by an opening snap, occurring just after the second heart sound, S2. The murmur is characterized by a low-pitched, diastolic rumble, and ends with a presystolic accentuation. When it comes to diagnosing valvular stenosis, Not all imaging tools are created equal. That's why the American Society of Echocardiography, or ASE, has laid out clear, evidence-based guidelines to help us assess valve disease accurately and consistently. These methods are divided into 3 recommendation levels, based on strength of evidence and expert consensus. Let's break them down. Level 1 recommendations are your gold standard. These are the methods that are not only appropriate but strongly recommended for all patients with valve stenosis. They're your go-to, first-line tools, reliable, proven, and central to routine clinical evaluation. They include 1. Mitral valve area by annimetry, wherein you directly trace the valve opening from the peristernal short axis window, MV level. 2. The mean pressure gradient, which is obtained using pulsed wave Doppler across the mitral valve. 3. Pulmonary artery systolic pressure, which is estimated using the tricuspid regurgitant jet, meaning the continuous wave Doppler is sampled through the tricuspid valve, typically in the apical 4-chamber window. And lastly, pressure half-time, which reflects how quickly the left atrium empties into the left ventricle. These tools not only confirm the diagnosis, but help classify the stenosis as mild, moderate, or severe. For example, a mitral valve area greater than 1.5 square centimeters is usually mild. Around 1 to 1.5 is moderate, and less than 1 is considered severe. Level 2 recommendations are for when the Level 1 method doesn't give you the full picture. These tests are used selectively, often to clarify more complex or borderline cases, or to guide further decision-making when echo findings are unclear. Level 2 recommendations include, first, the continuity equation. It's based on the principle of conservation of flow, that is, what goes in must come out. By comparing stroke volumes at the mitral valve and LVOT, we can calculate the mitral valve area, or MVA, especially useful when p-nimetry is unclear or technically limited. Next is the PISA method, short for proximal isovelocity surface area. This technique estimates mitral valve area by analyzing flow convergence on the atrial side of the valve. It's helpful in moderate to severe cases, though it requires good color Doppler images and experience in proper setup. And finally, stress echocardiography, which can be performed using either exercise or pharmacologic agents like dobutamine. This test evaluates how the valve behaves under stress. It's especially valuable in patients with exertional symptoms but normal resting gradients. Level 3 recommendations are not advised for routine clinical use. However, they may still play a role in research settings or rare clinical situations, especially when other imaging methods aren't available or are inconclusive. For example, cardiac catheterization is a Level 3 recommendation for assessing valve stenosis. It's not recommended as part of the routine workup unless transthoracic echocardiography, or TTE, is inconclusive or technically limited. Let's dive deeper into the Level 1 recommendations. The mitral valve area by annimetry is one of the most reliable methods, but also one of the most technically challenging to perform. It requires a good quality image, proper timing, and precise alignment, because you want to be at the leaflet tips. You'll want to be in the peristernal short axis view at the mitral valve level. Tilt your tail inferiorly to get the narrowest opening of the MV that gives you that classic fish mouth appearance of the orifice. Scroll through your clip carefully and freeze it in mid-diastole when the valve is fully open. You'll usually see that the shape of the orifice is elliptical. Now you can start at any point inside the opening and proceed to tracing the MVA. In this example, our tracing gave us a mitral valve area of 1.97 square centimeters, which falls within the range of mild mitral stenosis. Next, let's look at the pressure gradient across the mitral valve, which is calculated by the machine for you using the Bernoulli principle. We start by using the continuous wave Doppler, placing the cursor through the mitral inflow, typically from the apical 4-chamber window. Make sure you're looking above the baseline, since blood is flowing up towards your probe, from the left atrium to the left ventricle. Once you've lined it up, freeze the clip and trace the mitral valve velocity time integral, or MVVTI. This will give us both the MVVTI and the mean pressure gradient. It's also important to report the heart rate, since gradient measurements are flow-dependent. Now, if your patient is in atrial fibrillation, which is often a consequence of mitral stenosis, you'll want to average 5 cardiac cycles due to the irregular rhythm. Remember, in AFib, there's no coordinated atrial contraction, so you won't see an A wave on the Doppler tracing, just a series of irregular passive flow patterns. We have an example on the right, where the mean pressure gradient across the mitral valve is 21 millimeters of mercury. That value falls into the severe mitral stenosis range. Note that a mean gradient less than 5 is considered mild, between 5 and 10 is moderate, and anything greater than 10 is generally classified as severe. Moving forward to our third level 1 recommendation for assessing mitral stenosis, we have our pulmonary artery systolic pressure. Pulmonary artery systolic pressure, or PASP, doesn't directly measure the severity of mitral stenosis. It instead reflects the hemodynamic consequence of it. In other words, elevated pressures in the right ventricle suggest that mitral stenosis is starting to affect the lungs and the right heart. So we calculate PASP by estimating the systolic pressure gradient between the right ventricle and right atrium. This correlates closely with mitral valve resistance. The formula is PASP equals 4 times tricuspid regurgitation velocity squared plus the estimated right atrial pressure. We estimate RAP by evaluating the inferior vena cava, or IVC, using a subcostal window. Specifically, we look at two things: the diameter of the IVC and how much it collapses with inspiration, also called the sniff test. The IVC reflects central venous pressure because it drains directly into the right atrium. If the IVC is small and collapses completely, the right atrial pressure is likely low. If it's dilated and doesn't collapse much, the pressure is elevated. The ASE provides a reference table to estimate RAP. For example, an IVC diameter less than 2.1 centimeters that collapses more than 50% with a sniff suggests a normal RAP of around 3 millimeters of mercury. Intermediate findings fall somewhere in the middle, around 8 millimeters of mercury. If the IVC diameter is less than 2.1 centimeters and collapses less than 50%, or if the IVC is dilated and collapses more than 50%. If the IVC is dilated to greater than 2.1 centimeters and collapses less than 50%, RAP is estimated to be high at 15. Let's break this all down to 4 steps with actual examples. Step 1. Start by getting a good apical 4-chamber view and place your continuous wave Doppler through the tricuspid valve. Now align your Doppler beam with the TR jet, look below the baseline, and trace the peak velocity. This value represents the pressure gradient between the right ventricle and right atrium, which you'll use to calculate PASP in the next step. So why are we measuring tricuspid regurgitation when we're talking about mitral stenosis? When mitral stenosis becomes significant, blood backs up into the left atrium and eventually into the pulmonary circulation. Over time, this leads to increased pressure in the pulmonary arteries, which can then strain the right side of the heart, leading to a consequence or mitral stenosis, tricuspid regurg. Step 2 is to estimate right atrial pressure, or RAP. To do this, switch to your subcostal window and get a 2D clip of the inferior vena cava, or IVC. Then, ask the patient to sniff. This creates a sudden drop in intrathoracic pressure and should cause the IVC to collapse if the right atrial pressure is normal. Measure the IVC diameter and observe how much it collapses with that sniff. You can choose to measure it at peak collapse, or if needed, eyeball whether it collapses by more than 50%. This step is important because the IVC is a direct pathway into the right atrium, so its size and collapsibility give us a good estimate of central venous pressure and therefore RAP. For example, if the IVC is less than 2.1 centimeters and collapses more than 50%, RAP is 3 millimeters of mercury. If it's dilated and collapses less than 50%, RAP is high and estimated at 15 millimeters of mercury. Intermediate findings will fall at 8 millimeters of mercury. In our example, the IVC diameter measured 2.5 centimeters at rest, so it's dilated. When the patient sniffed, the IVC collapsed to 1.1 centimeters. That's a collapse of more than 50%. So according to the ASE guideline table, we would estimate the RAP as 8 millimeters of mercury. This value will be added to the TR jet gradient in the next step to calculate pulmonary artery systolic pressure. Step 3 is to plug in our values to calculate pulmonary artery systolic pressure, or PASP. The formula is PASP equals 4 times TR Vmax squared plus right atrial pressure. In our case, the tricuspid regurgitation peak velocity, or TR Vmax, is 2.64 meters per second, and the right atrial pressure, based on our IVC measurements, is 8 millimeters of mercury. Let's do the math. 4 times 2.64 squared equals approximately 27.9. Add the right atrial pressure of 8, and we get a PASP of 35.9 millimeters of mercury. Now the last step is to evaluate. Step 4. According to the ASE guidelines, a PASP of around 35 falls into the moderate pulmonary hypertension range. This tells us that our patient is beginning to experience elevated pressures in the pulmonary circulation, likely as a hemodynamic consequence of mitral stenosis. Let's move on to another important method for assessing mitral stenosis, pressure half-time, or PHT. It is measured in milliseconds. PHT is the time it takes for the pressure gradient between the left atrium and left ventricle to fall by half during diastole. On Doppler, this means measuring from the peak of early diastolic flow to the point where the gradient has dropped by 50%. Now, the good news is, most machines calculate this automatically when you trace the mitral inflow VTI envelope, which should appear after the T wave on the EKG. To obtain this, use continuous wave Doppler through the mitral valve, typically in the apical 4-chamber view. Then bring the baseline down because the MV-VTI is above it. Trace around the VTI. Then the machine will automatically compute for your MV-VTI values, Vmax, mean PG, and PHT. Why do we care about pressure half-time? Because we use it to estimate the mitral valve area using this simplified formula, MVA equals 220 divided by PHT. So for example, if the pressure half-time is 163 milliseconds, then the mitral valve area would be 220 divided by 163, which equals 1.35 square centimeters, which indicates a moderate mitral stenosis. Remember, the smaller your valve area, the more stenotic the valve is, because it indicates a smaller orifice for blood to flow into. PHT is particularly useful in patients where planimetry is difficult, or when an alternative MVA estimate is needed. To wrap up, here are the 4 primary methods we use to evaluate mitral stenosis severity, all recommended by the ASE. First, there's mitral valve area by planimetry. This is a direct measurement, done by tracing the valve opening in the peristernal short-axis view, usually at the leaflet tips. When acquired correctly, it has the best correlation with actual valve area, but it takes skill and image quality to get it right. Next, we have the mean pressure gradient. Using continuous wave Doppler from the apical view, we measure the velocity of blood flow through the mitral valve. From that, the machine calculates the average pressure difference between the left atrium and left ventricle during diastole. It's a quick, reliable tool, but keep in mind, it's flow-dependent, so heart rate and rhythm matter. The third tool is pulmonary artery systolic pressure, or PASP. This doesn't measure stenosis directly, it reflects the hemodynamic consequences from the right side of the heart. We estimate it using the tricuspid regurgitation jet and IVC collapsibility to calculate how much pressure is backing up into the lungs because of the narrowed mitral valve. And finally, there's pressure half-time. This measures how long it takes for the transmitral gradient to fall by half. From there, we can estimate the mitral valve area using a simple formula, MVA equals 220 divided by PHT. It's especially helpful when planimetry isn't possible. Together, these 4 methods give us a more complete picture, combining structure, flow, and functional impact. That's why a comprehensive approach is key in every mitral stenosis evaluation. Each method offers a different perspective, structure, flow, and consequence. Thanks so much for watching. I hope this helped you understand mitral stenosis a little more clearly and gave you the confidence to apply these concepts in both class and clinical settings.